Sex in sports, caring for the female athlete, specifically talking about ACL injuries. This was a symposium at the American Academy of Orthopaedic Surgeons in March of 2016, and I was asked to give the talk on ACL injuries and what sex differences we really see. A poster was done, Sex-Based Considerations in Caring for Common Sports Injuries. These were my co-workers on this project, and I think this was very well received. You can see the link there where you can look at more information from the Women's Health Issues Advisory Board, or WEHAB. I was privileged to be involved in this advisory board, and there are a lot of dedicated people who are very interested in advocacy, advancement, and serving as a resource on sex and gender differences in musculoskeletal health. I suggest you visit that website, and if you can, participate in the advancement of female athletes, female scholars, female scientists in any way that you can. So 30 years after appreciating non-contact ACL injuries had higher rates in basketball, this will be a talk about what progress have we really made. This is the athletic training room at the USOC in Colorado Springs, where I took care of the female athletes in 1984 and 86. And this was before the Dream Team men's team were picked, with only pros and 2 amateur. So we had comparable groups to compare to. And Cindy Wall and I did a study of a survey of the elite level basketball athletes who made it to Colorado Springs and were there to try to get a spot on the Olympic team. So this is Cheryl Miller on the right. Her brother is Reggie Miller. She tore both of her ACLs. She was very interested and insistent on continuing to be in every phase of basketball, so she helped us as a manager, a water girl, and we all helped out, and we had a great time taking care of these dedicated basketball athletes. So this is this study that was presented at the American College of Sports Medicine in 1989, and it was written up in MSSE. Our study was these Olympic competitors who were chosen as being the elite by basketball coaches. There were 80 males and 64 females. And really the message is there was a significant increase in injuries, particularly ACL injuries in females compared to males. So the number of females who had injuries was 34 out of those 64, or 53%, and males were only 11 out of 80, or 13%. The athletes who underwent surgery, 20 total underwent surgery, but a much greater rate of surgery in the females, where 20 of these had 21 surgeries, or 31% of the females had had surgery. And they're back competing at that elite level. Talk about dedication, what orthopedic surgeons can do, but more importantly, how motivated they are to return to their sports. ACL reconstructions were done in 2 of the 80 males and 8 of the 64 females. When we look at ACL injuries and management, epidemiologically, female-male ratio rates are different. Significant differences in basketball and team handball. And these are studies that are done internationally. Your references down there. The NCAA kept injury surveillance forms where they surveyed 16% of member institutions. Basketball is on the top, soccer is on the bottom. So this is probably the best comparison of females to males over this 15-year period from 89 to 2004. The denominator is 1,000 athlete exposures, So this is rates of injury per athlete exposures. You have to have that denominator. And if you look, it does kind of vary year to year, but overall the average rates of women to men basketball injuries is 3.4, and average rates of women to men soccer ACL injuries is 2.75. So over these 15 years, it really didn't change a whole lot, and the average remained very high. Despite some changes in training, some other intervention parameters, females being more active earlier, there still is a significant difference in basketball and soccer in the rate of ACL injuries. Almost 3.5 times in basketball and almost 3 times in soccer, girls compared to boys. So the incidences that are a lot greater, reported as 2 to 8 times greater, are in basketball, team handball, which is more of a European sport. In Norway, Greta Mikkelbust has done a lot of great research on team handball, and they've captured many mechanisms of injury. Also netball, alpine skiing, and soccer. What about the increased risk of second ACL injuries for female soccer athletes? In this study out of the Mayo Clinic, there were 180 female ACL reconstructions, retrospective study. 90 of these were soccer athletes, 90 were non-soccer athletes. They had a 5.8-year follow-up. ACL graft tears and contralateral tears were significantly greater in soccer athletes than non-soccer athletes. Return to soccer and older age were significant factors for ACL re-rupture, but not contralateral tear. So the bottom line is female athletes were more likely to tear their contralateral side than their reconstructed side. Our ACL reconstructed side is better than the normal side, so do we let them play earlier? Certainly not. We must do a in-detail discussion with them about returning to play soccer, what the long-term problems can be. If they tear their opposite side and now have 2 reconstructed side, they may not be at that elite soccer athlete level again. And our big question is, what is the future of arthritis in these reconstructed knees? Higher than we as orthopedic surgeons would like to admit. Increased risk of second ACL for these female soccer players. The graft tear for the soccer players, 11% versus 1% for the non-soccer players. And that contralateral tear, 17% versus 4%. Statistically significant at the P greater than 0.01 level. Risk factors resulting in ACL injuries. There are some that are not modifiable. This would be anatomic, structural, and hormonal, which are unique to females. Most think tanks and studies and discussions that have been done feel that the risk factors are really more in a modifiable category, and these are neuromuscular, biomechanical. So we should emphasize the modifiable factors for return to play and prevention programs. Yes, female athletes should continue to play and be very active. However, we can do anything to reduce the risk of ACL injuries or maximize how we know when they should return to play. Those are things that our female athletes certainly deserve. There are no sex differences in notch size and shape. Tibial slope on sagittal measurements, the normal is about 10 degrees posterior. There's a greater posterior slope. There's a greater risk for ACL injury. There are no sex differences in the size of the ligament. I think we'll see more written on this, the shape and sizing of the femoral condyle, size and shape. I don't think that it's a sex difference, but there probably is individual or perhaps different country differences in the shapes of our bones, and this will be a significant factor as we are able to assess size, shape, slopes of the bony morphology of the knee. This is a picture on the upper left of a congenital absence of the ACL. You can see that there's no notch there. Why is there no notch? Because there's a vestigial or essentially no ACL. So the notch forms in relation to the size of the ACL. In the lower left, there's a normal ACL and a normal notch. Smaller ACL, probably a smaller notch. In a study that we did looking at analysis of the relationship between the size and shape of the intercondylar notch, we didn't really notice any difference in the shape, like A or U. As you can see, U in the upper left, that's more of an A in the lower left. So the shape really didn't matter, and there really wasn't a sex difference, but if there was a smaller notch and a smaller notch ratio, femoral width to notch ratio, there was a greater chance of ACL tear, greater rate of ACL tear rates. So it wasn't related to sex, it was related to the size of the notch compared to controls. These were our study numbers: 108 ACLs, pretty equal boys and girls, 186 intact ACLs. So we looked at these different parameters, and again, there was no sex difference. There was a difference if you had a small notch, indicating perhaps a smaller ligament at risk for ACL injury. The bony morphology: the female knee does have a less wide and significant different medial, more than lateral femoral condyle. We'll see more about this as we get into advanced imaging with 3D CT and other images. What we do with this information is something that we'll have to figure out. The tibial plateau geometry: there was no sex difference in this study by Gibson. However, they did develop a tibial plateau risk model looking at the medial and lateral slope and also the medial tibial depth. The odds ratio, if you had 1 millimeter less medial tibial plateau depth and 1 degree greater tibial slope, you were at increased risk for ACL injury. We'll see more about this bony morphology and measurements in the future, I'm sure. These were their images from this article, and you can see you need a CT scan, you need standardized measurements to make these measurements, measuring both the medial and the lateral slope as well as the depth. Intrinsically, data are insufficient to make any conclusive statement regarding menstrual cycle of knee laxity and on the rate of ACL injuries in females. So there's no evidence to change participation and activity in game or practices based on the day of the cycle of the female. Cycles can certainly be variable in our active females. The self-reported where you are in your cycle is not as accurate as urine or hair analysis or blood analysis. What about genetically? There is a COL5A1 gene that is associated with increased risk of ACL tears in females. This is a gene that includes alpha-1 chain. This is the type 1 collagen of ACL, type 5 collagen in the Achilles tendon. So we'll see more and more about the genetic predisposition to certain injuries, certain diseases, cancer, etc. Hypermobility or excessive joint laxity is associated with increased incidence of musculoskeletal injury. So this is certainly more common in a female to have this excessive joint laxity. Extrinsically, kinematic, there's valgus collapse and increased knee abduction moment in the female athletes that are landing in studies Hewitt, Meyer, and Ford have done in the past. They looked at 205 female athletes, tested them, 9 ACL tears. Those ACL tears, there was a greater abduction moment that predicted ACL injury at a significantly great level of P less than 0.001. Hewitt studies have been very important in our understanding of differences in landing patterns in females compared to males. When we look at these positions these individuals are in, normal individuals, no knee injuries. The male is on the left, female on the right. You can see a difference in the pelvis. In the female, she has a contralateral drop. Her hip is driven then into internal rotation and adduction. There's increased valgus at the knee. To remain upright, she has to externally rotate her tibia. Her foot is pronated. And you can see on the side view to the right, looking at her on the far right, she is in more lordosis than the male is, and she has a anterior tilt to her pelvis. So the pelvis and hip drive the position of knee, valgus, and the rotation involved in setting her up for patellofemoral problems or ACL tear. And the male on the left, you can see that his pelvis is level when he's standing on that right side. Hip over knee over ankle position is without rotation. Tibia is in neutral, the foot's flat. And then on the view on the right, you can see how he's straight and has a very non-rotated pelvis. Mechanism of injury, there's no real sex differences in non-contact mechanisms. Basically, it is a weight-bearing pivot shift that occurs, awkward landing. When you look at the schematic on the right, probably in the third pane is when they've torn their ACL. When it really looks ugly, they have already torn their ACL. Interestingly, we see very few patellar dislocations and very few medial collateral ligament injuries. So what you're seeing, or even it looks like it's valgus, but it's a functional pivot shift. So it looks to be in more valgus as the tibia goes forward and then goes back into place as the knee is flexed after the patient gets up from collapsing on the floor. This is a mechanism in basketball where driving down the court, she receives the ball in the paint, grabs it, and comes down awkwardly and tears her ACL. She is out of her cone of stability of her knee, and the ACL tears. This is a good one where the brain is thinking, I got to catch the ball, got to not go out of bounds, so she grabs the ball and unfortunately lands in that position of no return and tears her ACL. So this mechanism is VROOM, valgus rotation out of control movement. So you can see how she lands, again, out of her position of safety. Doesn't go out of bounds, but unfortunately tears her ACL. Takes 70 milliseconds to tear the ACL. If we could land with our feet underneath us in more of a cone of stability, that would be better, reducing risk of injury. This cone of stability, our goal is to land with our feet underneath the pelvis in a light as a feather, straight as an arrow type thing. This is the safe landing and would prevent lower extremity injuries. However, unfortunately, with momentum going forward, think about things like not going out of bounds, we oftentimes end up out of our cone of stability as on the right. How do we teach athletes to land in a safe position? By repetition, repetition, repetition. The position of safety is on the left. As we've talked about in those normal individuals doing mini squats, good hip over knee over ankle position. So we have to look at what is the best muscle activity, the agonist antagonist. So an ACL injury, we want our hamstrings firing. We want our hip abductors, extensors firing. So the position of safety shown on the left is normal lordosis, flexed hip, neutral lower extremity, flexed knee, so the hamstrings can be more efficient in reducing anterior tibial translation. Both feet landing in this position of no return. The body's forward, the hip is rotated internally, hip is adducted, more of a less flexed or upright landing. Knee is driven into valgus, leg is externally rotated, and landing on one foot out of control, and then the ACL tears, and there's that functional anterior tibial translation and then reduction as the knee is flexed, usually by the individual who's fallen on the floor and puts their knee into a flex knee position, so then the IT band and hamstrings reduce that anterolateral dislocation of the knee. Prevention and post-ACL rehab programs really are similar. There are no sex differences. Teaching them to land in that safe position, doing a lot of cross patterns, a lot of things on the field in the rehab facility, not as much about heavy lifting as it is about balance and movement and ability to move your feet. This was a think tank that was done at Hunt Valley, headed up by Edie Hunter Griffin. And there is actually a review of what we found and a manual on prevention of ACL injuries. What do the prevention programs have in common? The emphasis is on safe landing, neuromuscular recruitment. It should be sport specific. Soccer is not like basketball in a lot of the skills. The program must be done properly and participation documented. And we really need to look at all lower extremity injuries because ACL injuries are frequent, but they're not that frequent when you're doing studies to look at prevention. So we should look at ankle sprains, lower extremity injury, stress fracture, and not just ACL tears. This is our UK ortho program that we use for prehab, is what we call it. So I would suggest that you look at some of these and work with your athletic trainers and physical therapists about what is sport specific, what your athletes will do, and more importantly, what will your coaches allow the athletes to do, and do it on a repetitive basis. This should be a season-long type activity. Landing is everything. If we could get rid of gravity, we wouldn't have a lot of injuries, such as ACL injuries. So teaching proper landing techniques is very important. There are differences in sports that males and females participate in. These are obvious in these two videos. You have figure skating, a landing pattern that is much different, and then you have professional wrestling on the right. So different amount of estrogen, testosterone, and different skills in the sports. So there are true differences in the sexes, and there should be. There are differences in the way men and women perceive themselves as well, as evidenced by the female on the left and the male on the right. This is just fact. Who's driving the ACL return to play train? It should really be the physicians shown here at the caboose. So we can't lose control if we operate on the individuals. We can't say, oh, you're a junior soccer athlete, you have to be able to play in the showcase and get a scholarship at 2 months after your ACL reconstruction. We must be the protector of the patient and sometime become the parent, because we want to protect that knee, hopefully to return to play, but hopefully for the rest of their lives. So we do need to make sure we are in charge and driving the train and work closely with athletic trainers and physical therapists and turn it around where we regain control of the train. We have it at the time of surgery, but sometimes we lose it as they're going through the rehab process. Thank you for your attention. This is a .com where there are more presentations. Protect our female athletes.